Well, thank you so much, Bruce, and good morning to everyone. I want to thank Professor Johnson as well for that very kind introduction and say how honored I am to join you all. So, I know we're going to talk about the impact and interconnection of civic engagement and population health, and I'm going to take this discussion a step further and discuss the consequences of unrepresentative government and policies and how we got here, how we got to the state of affairs, right? When we talk about the striking health inequities in our society. Um, Next slide, please. So, so I wanted to make sure that we know that inequality gets under our skin and it leads to accelerated aging or biological weathering, as Dr. Arlene Geronimus at the University of Michigan has demonstrated. It increases our rates of chronic diseases as among these population groups, as other researchers have identified. And it, of course, leads to the intergenerational trauma in these communities over time. Simply stated, the nation's health is not an organic outcome. It's not a coincidence that certain groups of individuals in this country or certain groups actually experience higher premature death rates and poor health outcomes than others. But why? Why is that happening? Today, we recognize that a variety of forces collectively impact our health and determine the quality and the extent of our lives on this earth, of course, including the social, environmental, behavioral health determinants. Key among these determinants, it is argued, are the social determinants of health. The structural conditions in which we are born into, we live in, and we die. Could you go back one slide, please? So these social determinants of health, as researchers have demonstrated, play an outsized role in these human-made pre-existing health inequities. But underlying each one is a political determinant that we can no longer ignore. Too often we've stopped at the social drivers of inequities, failing to look back and dig even deeper to see the depths of the problem and understand their root causes and distribution. And as a result, we've been missing the link between the social determinants of health and their political or policy roots. So the first thing we need to grapple with is the concept of the political determinants of health. I think most everyone viewing this workshop understands either explicitly or implicitly what the social determinants of health are. But what is important to realize is that for every social determinant of health, there was a preceding legal, regulatory, ordinance, legislative, or other policy decision that resulted in the social determinant of health. Those are the political determinants of health. So as we think about the social determinants of health, we need to think about how they came to be in the first place. Why is it, for instance, that communities of color have the highest rates of asthma throughout the United States? In New York City, it has been tied to the disproportionate number of bus depots in Harlem. How did that happen? In other parts of the country, it was tied to major highways or railroad tracks running through these neighborhoods, cutting the neighborhoods in half. What instigated this result? At all levels of government, we have seen how these political determinants have worked for centuries to hinder health equity for some or advance it for others. Research has also shown that the impact of slavery has been associated with long-term effects on contemporary mortality, poverty, heart disease, etc. Early on, policymakers worked with commercial interests to sustain their horrific business model of slavery, or unconscionable acts against indigenous groups by enacting public policies. And as if that weren't enough to keep a group of marginalized groups down, the policymakers went further to create additional policies that prohibited these groups from congregating, walking at night without passes or without lanterns, raising their own food, earning their own money, or learning to read and write, essentially making it difficult for these groups and for others to address their social determinants of health. You see, these facially discriminatory policies were then recycled from one generation to another into the late 1800s, from the 1600s, 1700s, into the late 1800s. Afterwards, though, we saw a movement from explicitly racist policies to facially neutral policies, which basically had the same effect once they were implemented, Consider the Homeowners Loan Corporation Act that redlined neighborhoods in over 200 cities across the country. The Housing Act that displaced over 500,000 African Americans and other minorities. Or the Highway Act that led to the placement of major highways in predominantly black and brown neighborhoods. Next slide, please. Today we can see the impact that prohibitions and restrictions on civic engagement have had on vulnerable and marginalized groups, especially when it comes to minority health. As we move forward, it's important to understand the political levers that have been pushed and pulled to hinder or advance health equity in America, and to define the political determinants of health. So here's our definition of the political determinants of health. They involve the systematic process of 1, structuring relationships, 2, distributing resources, and 3, administering power. And they operate simultaneously in ways that mutually reinforce or influence one another to shape opportunities that will then result in the advancement or hindrance of health equity. So if you look on your screens, if you break it down, look at structuring relationships. We talked about redlining in America, the Homeowners Loan Corporation Act, but there are a host of other laws and policies that were created. The anti-miscegenation laws designed to keep population groups from mixing, the blood quantum requirement laws placed on Native American communities, the immigration law steeped in racist ideology, etc. You look at the distribution of resources, right? You think about it in terms of appropriations of federal, state, and local discretionary and non-discretionary funding and programs, the dearth of health services or special education services in these communities. If you think about administration of power, right, as we think about civic engagement, the redistricting process, gerrymandering, including restricting ballot access, voter suppression tactics, the voter identification laws, and the list goes on. Next slide, please. This model shows that the political determinants of health operate simultaneously in ways that mutually reinforce one another and concurrently impact or are impacted by a continuum of interacting barriers and interventions. You see, those of us who aspire to advance health equity focused policies must overcome these barriers and leverage interventions and address other competing and equally complex determinants of health. You see, this is a continual strategic process, as you heard Professor Johnson mention, that doesn't end once a policy is realized, but requires constant monitoring by advocates to determine whether a law or other policy or governmental action is positively or negatively affecting any aspect of the process, including civic engagement, and of course, ultimately, the advancement of health equity. You know, the good news as I close is that the structural barriers and the resulting inequities are not permanent, but it's going to take greater civic engagement and collective agreement from individuals committed to stomping out inequities to formulate the strategies and the policies to overcome them. Thanks so much.